to do a quick introduction of Zoe Arvanatakis. She's a board-certified neurologist and subspecialist in cognitive neurology. She provides clinical care to families affected by Alzheimer's disease and other dementias. She's a professor, medical director at the Rush Alzheimer's Disease Center, an academic physician leader at Rush, and past chair of the geriatric neurology section of the American Academy of Neurology. And she truly is an award-winning educator and NIH-funded clinician scientist. And I am delighted to say that I have had the joy of working in the clinic that Zoe runs. And honestly, a lot of what I know about dementia has been the result of what I've learned working in the clinic and learning the things that I needed to learn. So it's a delight to welcome you, Zoe. And I'll hand it over to you.
Thank you so much. Thank you. And then were you going to show any other slides, Kirsten, or talk about past session? Or, oh, I thought you were going to. Okay, perfect. Okay, so let me share my screen. And sorry, everybody. Let me just get organized. Okay. Great. So I was asked to talk with this group a little bit about dementia. Sorry, the computer's a little slow, but I did press presentation mode. Hopefully it will come up. There we go. So I think what I wanted to do is talk a little bit about what we know, but also talk about new things. So talking about dementia research and care, certainly it's been a very kind of exciting field in the last couple of years, as I'm sure many of you heard. And so I'm really delighted to be here. Thank you very much for inviting me. And I have just under 50 slides to go through, and some of them are going to be rather quick, but essentially I primarily spend my time doing NIH-funded research. I'm principal investigator of a variety of different grants, and I'm involved in research at different levels, which you'll hear a little bit about, but that's not really the focus of our talk today. And I really don't have any conflicts of interest for the presentation that I'll be giving. So I thought that by way of kind of framing what we wanted to go over today is talk a little bit about differential diagnosis of cognitive impairment and dementia. I'm not sure all of you see dementia in your clinics, so I wanted to go through some of that. And please, Sandy, tell me if this is not of interest to the group, because I can go quicker through these sections. But I mean, in other words, if all people on the call today are involved in dementia clinics, I really don't have to spend too much time on this, but tell me, it's hard for me to know with the audience.
Most of us are not involved in dementia clinics, looking at the list here. And if anyone has your microphone on, if you would please turn it off, because we want to hear Zoe and not what's going on in your home.
Okay.
If we please.
Thank you.
Thank you.
Okay, but please, Sandy and others, please let me know if these are things and I'll go quicker through certain sections if it's not important. But I thought that the audience wouldn't necessarily be dementia experts per se, so I wanted to talk about thinking through how to evaluate what can be causing cognitive impairments. We'll talk about differential. We'll talk about initiating a diagnostic evaluation. That might be something you want to do in your clinic. Thinking about the etiologies, and then talking a little bit about kind of upcoming and ongoing research, but also the novel therapies. I think there was already a question actually about aducanumab, so we'll talk about that in the Q&A session. But really thinking about some foundational concepts, and then when to refer to a specialty clinic like the one that we have at the Rush Memory Clinic, which is part of the Rush Alzheimer's Disease Center. So a few words about the context first, just to set the stage if you don't think about dementia in your day-to-day life. But it is certainly a very large and a very rapidly growing public health burden across the globe. So we know currently that there's already 55 million people worldwide who have some form of dementia, and that number is quickly growing, so that by the year 2050 here, In the red box, we see that there'll be 139 million people with dementia around the world. So this is a huge problem, and particularly more rapidly increasing actually in the low middle income countries compared to the higher income countries. So it's going up around the world, but especially affecting countries where they are the least prepared to deal with this massive public health problem. We also know that the annual cost of dementia reached $1.3 trillion in the US in 2019, and it's even higher now. So this is a very, very big burden, not only at the societal level in terms of obviously how it affects communities, but also, of course, it affects society as a whole because it's a very, very chronic and expensive condition to tackle. Now, within the US, we also have more specific numbers. We know that there are currently 6.7 million people in the United States who have Alzheimer's disease now, and that is expected to grow to nearly 14 million by 2060. The cost in the US is in 2023 estimated to be at 345 billion people, and that's not including an equal amount of money that goes towards informal caregiving, which is a huge burden emotionally, financially, and in many ways for families who are carrying the burden for informal caregiving. Alzheimer's disease is not only common and chronic, but it's the sixth leading cause of death in the United States. And so this is really just a devastating condition. So I wanted to go over with you some of the key clinical features of cognitive impairment and dementia. And so firstly, to start out with, neurocognition, or you might hear me using the term cognitive function, is a function of the brain, a very important function of the brain, but it is certainly something that we can evaluate and recognize that it lives on a spectrum, and a spectrum that changes over life course. So certain cognitive functions you can become more astute at, and certain other ones can decline with aging. So there's certain patterns that we observe, and throughout the life it's not equal. So you're born with a certain function, and typically cognitive functions develop quite rapidly in childhood and throughout adolescence and early adult life. Then you have a little bit of a plateau, but then through menopause, and also for men, changing of hormones later in life, there's changes in cognitive functions, and then certainly in late life there could be additional changes. Now, neurocognitive impairment itself is quite common as people grow into their latter part of life, and it's thought to be even more common than the more advanced changes that you see with a full-blown dementia. But the neurocognitive impairment, even if you don't reach a full-blown dementia, is associated itself with poor health outcomes and other consequences for life, including financial, social, and many others. So it is an important condition to learn about and recognize and research. This was a schematic that was published in 2019, which I appreciate because it tries to make the distinction between what can happen as part of aging, where there's not a neurodegenerative process underlying it, versus what you see in a disease state like Alzheimer's disease. So early signs could be repeatedly forgetting things, asking the same questions over and over, having trouble managing your day-to-day life, whether it be managing your own medications or paying bills. There tends to be a lot of psychosocial changes that happen as well, like, for example, being much more withdrawn and not participating in events, or going to events and not really being engaged. And there could be troubles with navigation, like, for instance, while driving and so on. So it's suggested that if there's significant changes in your ability to function in your day-to-day life, that you consider talking with a healthcare provider, and kind of thinking a little bit about what your wishes are now, sooner rather than later, because it will be much more difficult to articulate your wishes if cognitive functions continue to decline and become in the frankly impaired range. We did publish a review article in JAMA on dementia itself, talking about diagnosis and management. So some of the slides I'm going to be showing to you. Just a handful of slides throughout the presentation are actually pulled directly from that article, because I thought that it's a nice way to summarize some information. And more recently, JAMA approached me to write a similar review article for mild cognitive impairment, which we'll talk in a little bit about that specific clinical entity in just a bit. But I think the point I wanted to make is that when we think about dementia, we very quickly think about cognitive changes, which obviously are very, very important in that condition. So memory loss, word finding difficulties. In later stages, you have much more significant cognitive problems that typically manifest as severe memory loss, and then trouble across all domains, including not only language, where you lose ability to talk and eventually also ability to understand, and you can have a global aphasia, but really all cognitive domains become impaired, including attention skills and visual spatial skills, and many other skills are impaired. But the point of this table is to point out that in dementia, you very often get psychological changes. Again, you can think of them as early and late phases, where in earlier phases you might have depressive symptoms, apathy, withdrawal, as we spoke about before, as a behavioral symptom, and disinhibition. You have changes across sleep and physical activities. And then in later manifestations, you can get the more frank aggression, hallucinations, delusions, altered sleep-wake cycle, and so on. So this is just kind of a table that can help you frame what to look for at what stage. But of course, there's a lot of variability, and some people have earlier manifestations than what I have on this table, or later. And there's of course many other things that cannot be included comprehensively in a table like this. So what are some of the diagnostic features in terms of cognition? Dementia itself is characterized by a cognitive impairment that you see across multiple domains. Usually, in most cases with Alzheimer's disease, it starts with episodic memory or short-term memory around specific events. But you also look for impairment in at least one other domain, such as language, as we spoke about already, or visual spatial skills, executive function, and otherwise. But this cognitive impairment needs to represent a decline from a prior level of function. So it's not something you're born with and it's stagnant throughout life. This is something that you develop, and it represents a decline from your previous level. And a really critical feature of dementia is that it impairs your day-to-day functioning. So whether it be in your social environment, in your occupation, in your self-care, there needs to be a translation of that cognitive problem into actual impairment in your functional abilities. So the most common form is a mixed dementia, and we're going to come back to that. But there's certainly individual diagnostic entities which we need to consider, most commonly Alzheimer's disease and several others that are less common. And the point of this slide is to make the distinction with an entity that we call mild cognitive impairment, in which you do have loss of cognitive abilities as well. Very often it is also in the memory domain, so we would call that an amnestic mild cognitive impairment, or MCI. But you can also have non-amnestic MCIs, and you can have multi-domain MCI. But the key distinction here with dementia is that this doesn't represent significant enough impairment to affect your day-to-day life or your independence. So these patients still have relative independence, can still function, some still work. And so the criteria for dementia per se are not met. Now, the interesting thing, which I didn't really emphasize in the article, but I put in blue on the bottom right, is that now we recognize that that MCI itself is on a spectrum, and that there are earlier stages of MCI. And sometimes in the clinic, I kind of use the non-typical terminology of pre-MCI patients that we see. These could be people who have very, very subtle cognitive problems, who might not really demonstrate the objective cognitive impairment that we see in MCI. Or they might be very subtle if there are cognitive changes that we see on the neuropsychological testing. But it's also a group of people that have subjective cognitive complaints that we and others now have published are at much, much higher risk of developing MCI, dementia, and also the neuropathology of dementia is associated with the subjective cognitive problems. So when we look at postmortem brain after somebody passes, people who have subjective cognitive impairment do have significantly increased neuropathology in the brain. So there is something ongoing there, and we might not be as astute enough to really measure what that is. Now, one step yet even earlier in the whole disease process is this asymptomatic Alzheimer's disease. So they don't even have any symptoms. They're not complaining of cognitive problems. But we are now able, with some of our kind of advanced biomarker testing, able to evaluate some people in whom we suspect there will be a very, very high likelihood of them developing symptoms in the years to come. So we have measures, and I'll tell you a little bit later about that, whether it be on MRI or on CSF testing, that we can now evaluate as them having evidence of Alzheimer's disease based on the biomarkers, and yet they do not have yet any symptoms. So that's a really important group to study and understand as well. So again, just honing in on the idea of that cognition is across a spectrum. You can have normal cognition well into your 90s or even older, and never have any manifestation of changes in your cognitive function that's really to bear on your quality of life. Some people develop mild cognitive impairment. Some people develop a full-blown dementia. But it's important to know that it's not because you say shift from normal to MCI that you're necessarily going to progress to dementia. Some people bounce in and out of an MCI state with normal, so that can happen over the space of several years. But certainly having MCI does put you at a higher risk of developing dementia. So it is a clinical entity that we want to recognize and certainly monitor and help these patients with. If we think the cause is an underlying neurodegeneration when they have MCI, that is also a group that we want to recognize and potentially help. We do have some options now to offer those patients. So I recognize I'm talking to a group of psychiatrists. And so, there was a huge effort about 10 years ago to rethink the classification of these conditions. And so it was proposed that there's mild neurocognitive impairment, which is essentially, I think, very similar to what terminology we use for MCI, mild cognitive impairment. And there's also major neurocognitive impairment that was identified where you have two or more domains that are affected, where you're looking at the standard deviation of from the norm for function on neuropsychological testing, interfering with your independence, and not due to these other medical or psychiatric conditions. So that's essentially, what we would call dementia. I myself in clinic don't really use this terminology because I find that it's very confusing for patients. So when we're talking with patients, talking with families, I think it makes much more intuitive sense to use the words mild cognitive impairment and dementia. And even a lot of patients and families confuse dementia with Alzheimer's disease. So we spend a lot of time kind of disentangling the difference between those two terms. So we try to keep things a little bit more tangible and simple in our clinic. So I don't use this terminology, but I do recognize, of course, I'm talking with this group that uses a different classification or terminology than we do, I should say. So what about differential diagnosis? So obviously, when we're thinking of somebody developing a new cognitive problem, neurocognitive impairment or dementia, we also want to think about potentially reversible and treatable causes. So this is again from the JAMA article that we published a few years ago now. But so we want to think of metabolic disorders. And so I list some examples, whether it be B12 deficiency and hypothyroidism. So these are things that we routinely test in our clinic and all our patients to make sure that they're not deficient in these, because this is obviously very simply treatable with replacement therapies, either over the counter or prescription in the case of thyroid. So we certainly don't want to miss that. There's also, we want to think of vascular processes that can be contributing. So, in the elderly, falling is a huge problem from multiple perspectives, but certainly from a perspective of cognition it is. So if they have subdural hematoma, these are things that we can easily identify on a brain scan and treat if appropriate, if big enough and appropriate. Epilepsy, of course, has its own treatment course, so we don't want to miss things like that. If there's a tumor in the brain, whether it's primary or metastatic or paraneoplastic, tumors can affect cognition, so we want to recognize those, and they have their own treatment approaches. Psychiatric disorders is kind of embarrassing to tell anything to this group about that, but certainly, it's very difficult in the early stages to disentangle depression from a neurodegenerative process that's developing. So I do want to recognize that, and it is it's very tricky, and that's why I very much cherish for the many years having Dr. Swantek in our clinic and helping us disentangle primary psychiatric disorders from a neurodegenerative disorder like Alzheimer's disease. Toxins, of course, are a big problem. Especially now that there's changes in behavior around use of cannabis and other types of agents that does affect cognition, but kind of something that comes to mind, of course, in our older population is polypharmacy is a huge problem. So there are individual drugs that are problems to use in older patient populations, whether it be benzodiazepines or so on, but also just multiple drugs. And so we're doing a lot of research in our group too, studying, using our databases, studying polypharmacy and how that affects cognition and neuropathology after death. Infections, inflammatory disorders, immune disorders, of course. You can think of all of these, and there's ways of testing these in blood and CSF. There are certain patterns on brain scans that we see for these disorders, genetics as well, and many others. So this is just kind of a flavor of the many, many dozens of diseases that can present with cognitive impairment in the elderly, which you want to consider if appropriate and do additional testing for if appropriate, because you don't want to miss those. So in addition to that, in a typical patient, how would you do a clinical evaluation? What testing should you do? And so at the very basis, you want to start with a very detailed medical history. Unfortunately, the presentation of cognitive impairment and dementia, these are conditions that take time to evaluate in terms of you can't just do a blood test and you're done. It's, we spend an enormous amount of time talking with the family members, talking with the patient. It's important to get that informant history or collateral history, whichever term you prefer to use, because sometimes the patients are just not, there's some agnosia, they might not recognize the problem, or even if they recognize the problem, they might not be able to really articulate the problem itself, maybe the extent of the problem, the course over the months and years that they've been having the problem, the extent of impairment in functional abilities. So you really need to spend time getting that collateral history. And many would argue that that's really probably one of the most important elements when you're doing a workup for cognition, is really getting a very detailed history of the condition and of other conditions, presence or absence of other conditions. So it's really about the medical history. In addition to that, we do examine patients. That's very informative. So direct observation of patients, observing cognitive abilities, observing behavioral abilities or dysfunctions. It points to a lot of clues. So, at the bare minimum, you want to do a screening cognitive test, but you might do some additional evaluation of higher order cortical function. A full neurological evaluation, you want to assess the cardiovascular status on the physical exam, and etc. So really get a comprehensive assessment. On the physical, we do tend to focus on neurological signs. We're looking for motor dysfunction, Parkinsonism, focal abnormalities that might point to a brain anatomical structural problem, whether it be a tumor, abscess, or something focal. And we look for systemic signs, whether they're signs of intoxication, cardiovascular disease, as we spoke about, and other conditions. We typically do blood testing at the bare minimum, thyroid function and B12, as we already spoke about, but there's of course a whole slew of other tests you might do on in the blood as indicated. And we at the bare minimum do structural brain imaging. We prefer MRI if possible. If not, a CT scan will do. And we might do additional types of functional imaging as needed. So the box on the right, again, from that same JAMA article, gives a little bit more detailed approach, which we don't have time to get into, but it is all there if you want to pull up that article. Now, the neurocognitive assessment, we do want to do, as we said, at the bare minimum, a screening tool. So, of course, for many decades now, since the early 70s, we have the mini mental state examination, MMSE. More recently, there's the Montreal Cognitive Assessment, which is more sensitive and a little bit more informative, perhaps. So we in our clinic have shifted to using that. We still use both, but we primarily use the MoCA. So these are very quick to give, easy to give, they're established, they have norms, but they certainly have weaknesses, and they're not very sensitive and specific. And I'll give you a prototypical example. As a person with high education like yourselves, who have many years of university and are very educated, these tests are really not that sensitive to pick up subtle cognitive problems. They're also not very specific. So you can do the test and it doesn't really help you distinguish different types of causes for the cognitive problem. But nonetheless, they help identify for many, many people that there is a cognitive problem. It's also an easy number that you can follow over time. So we certainly do use the same test over time in the same patient so we can compare where they're at in terms of their staging. It helps us counsel patients in terms of the stage of disease that they're in. So there's many, many advantages, and we certainly do use these tests, and many primary doctors' offices are able, are familiar and are able to administer these tests. So there's lots of utility and value to them. But we also consider doing kind of above and beyond that in terms of specific tools to assess cognition in more detail by doing neuropsychological testing that assess memory across stories or lists of words. We can assess working memory by using calculations with numbers, for example. We test attention by using digits forwards and backwards, where we give them a string of digits and get them to retain that and repeat it back at different epochs. We can evaluate language. So just observing the patient, you can hear the prosody. We can observe if they have word finding difficulties, their grammar accuracy, and so on. But we can test specifically language by getting them to name, to read, to repeat things, to comprehend. We test visual spatial abilities with a test of line orientation, for example, or copying figures, or just, sometimes in the clinic, I grab a magazine and I show them pictures of known political or kind of entertainment, famous people, and we try to evaluate whether they can really put all the pieces together to recognize a face. It's a complex brain task that's kind of localized to specific parts of the brain. We can evaluate for executive function, like their judgment given a particular scenario. How would they handle, a crisis, or how would they, you can get a sense. So you don't need specific, for a lot of these tests, you don't need specific neuropsychological testing, although that's very helpful and can give you a number and something to track over time objectively. But you could certainly use tools that you have in your clinic to observe any of these, including the last bullet point on social behaviors, their interactions with you. Are they disinhibited? Are they apathetic? So these are very, very telling, and also help us absolutely with our differential diagnosis. So the last bullet point is kind of getting perhaps it's something like a frontotemporal dementia that can present with behavioral changes, marked behavioral changes with relatively preserved memory function in the early stages, for example. So very telling. Now, the field is rapidly evolving, and we do have biomarkers that by and large, I'm going to say, are still used primarily in the research realm, but I think very soon we'll be moving into blood biomarkers. I mean, they're ready. Some are already commercially available, but but I think they'll become more routinely used in the next year or two. But for now, biomarkers are not necessarily routine practice. We do use MRI scanning, and there are now some really cool programs that help us quantify the amount of, for example, mesiotemporal lobe atrophy. We do use CSF where appropriate, and we can measure levels of amyloid, of tau. We look at ratios, we look at total tau, we look at phospho-taus. And we use neuroimaging. Of course, we already spoke about MRI. We can use PET scans. We don't really use SPECT that much anymore, although we could, but we're now getting into the world of amyloid PET scans and even tau PET scans. So things are certainly evolving very quickly and very informative, but we're not quite there yet to use these routinely. Now, in terms of the blood, the blood testing certainly offers advantages over doing CSF testing for Alzheimer's disease, and offer advantages over neuroimaging, including, of course, blood tests are much lower risk. They're much simpler, but also when we talk of simplicity, it's not only in terms of doing the blood assay itself, but also interpretation of the blood test is much easier than interpreting, say, an MRI or even the CSF testing. They're lower cost. The sample can be collected outside of a hospital setting. It can be done quickly, and it's also scalable at population levels. So much easier to do blood tests out in the community or for large populations rather than, of course, something like an MRI or lumbar puncture. but they're still not routine. We certainly have emerging biomarker data coming with Alzheimer's disease, p-tau. There's a 1-801, there's a 217, which looks perhaps even more promising. And so I think that this is a very rapidly evolving field, and I wouldn't be surprised if in the next year or two they start being more used in the clinic-based setting. Now, what about using blood for genetic testing? Well, again, this is not done in routine practice. There's little reason to order genetic testing in sporadic Alzheimer's disease. ApoE4 epsilon, which does increase, is associated with increased expression and earlier expression of Alzheimer's disease, is now done really for risk stratification and counseling of patients that were considering starting one of those new monoclonal antibodies like lecanemab. So we do use ApoE testing more now than we have before, and that's really in the context of trying to help us risk stratify patients. And we'll talk a little bit more about these new therapies in just a moment. And then in very rare instances where you think there might be an autosomal dominant cause of dementia in a younger person, for example, these patients tend to present in their 50s, maybe even in their 40s, and they have a strong family history of a first degree relative with young onset dementia, we might order a specific panel for presenilin mutations. There's presenilin 1, 2, there's APP mutations. There's also different mutations we look for in frontotemporal dementia, the MAPT mutations, and of course Huntington's disease. So they're very kind of rare situations in which we may actually order more specific autosomal dominant mutations that we now know about. But again, that's very rare. And in that, if you're seeing a patient that you suspect an autosomal dominant, you probably should be referring to a subspecialty clinic, because these are really different types of conditions. Now, let's move on to etiologies of dementia. So we're going to talk about common and a few of the less common etiologies, and a little bit about the pathophysiology of the most common cause of dementia, which is Alzheimer's disease. So common causes, so depending on the clinical course and other clinical features, you do want to think of common causes first. And so in kind of order, if you're evaluating somebody who's in their 70s, 80s, 90s, or older, you're really going to think first of Alzheimer's disease. You're going to think of neurodegeneration, and the most common neurodegenerative cause of dementia in an older person is by far Alzheimer's disease. Now, a runner-up, although far less common, is Lewy body disease, and far less common are things like frontotemporal dementia, hippocampal sclerosis, HS there for short. And then more recently, there's this condition called LATE, which is a manifestation of a protein called TDP-43, which is fairly common actually, but we're not really in the prime time in terms of characterizing what it looks like clinically. We have a much better idea how to identify it pathologically after death under the microscope, but during life, I have to say a few times I've considered that diagnosis, but it's very difficult. We don't really have the tools yet to identify a patient with this condition called LATE. So these are the conditions to think about. I'll just give the caveat that we have patients in whom we might identify, for example, Lewy body disease, but they're very more common than not. A patient with Lewy body disease, if you look under the microscope, they have a lot of coexisting Alzheimer's disease pathology, the plaques and the tangles that you see in Alzheimer's disease. So clinically, it's hard to distinguish, and pathologically, we very commonly see actually coexistence of a lot of these pathologies. So LATE will coexist with Alzheimer's, for example, or Alzheimer's will coexist with Lewy body disease. So these conditions are hard to distinguish clinically at times, and it's not surprising because in the brain we might be seeing both. The other coexisting pathology, which is super common in aging, is cerebrovascular disease. So these include things like frank infarcts, but also the vessel pathology itself. We see a lot of athero and arteriolosclerosis in the brain. And we and now others have published that even when you account for brain infarcts, for the frank infarction of death of brain, of the neurons and brain tissue, the vessel pathology itself does contribute to cognitive impairment above and beyond having a frank infarct. So these are important pathologies to consider and recognize if somebody has especially systemic risk factors like hypertension, diabetes, smoking, and others, because we might be able to do something about those risk factors and prevent more cerebrovascular disease. So those are important. This is what it looks like under the microscope. Often you see a mixed kind of presentation under the microscope. Alzheimer's disease, you see in the center panel there, your silver stain with plaques, which are the globs, and then you see the neurofibrillary tangles, which are deep within a neuron, which are, I don't know if you can see my cursor. Sandy, do you see my cursor when I'm moving it around here? No? Well, some people are saying yes. So this is a neurofibrillary tangle, which is within a neuron. So this is a very dark brown staining of the neurofibrillary tangle within the neuron, and you can see the shape of the neuron there. And then these globs here are the neuritic plaques, which are extracellular. These are outside neurons, outside glia, and the amyloid staining, which is shown with immunohistochemistry on the far right here. This is staining for amyloid, and this is staining for the neuritic plaques within the neuron. And here you see the nucleus of the neuron, which is blue in the center here. Now you also see a lot of vascular pathologies as the brain in brain and aged brains. Like here's a frank infarct, a hole where it should not be in the brain. Of course, these are the ventricles, so this part is normal, but this hole should not be there. And then we can dissect the infarcts, and we could see this is what it looks like on H&E staining. And then you could see vessel pathology. Remember, we were talking about arteriolosclerosis and atherosclerosis. This vessel pathology, this abnormal thickening of the vessels in the brain, is not good for cognition, even when you control in our analyses for the infarcts itself. And we can look for a host of other pathologies. So that's what it looks like under the microscope. So the clinical and pathological characteristics can be different across different causes of dementia. So here we have the common things are Alzheimer's disease and cerebrovascular disease on the left. Here, less common, Lewy body disease, and far less common is a frontotemporal dementia presentation. And in this table, what we're looking at is the different pathologies. So you can get atrophy in Alzheimer's disease. Of course, you get the plaques, the amyloid beta, tangles. In cerebrovascular disease, we spoke about the infarcts and about the vessel pathologies. And in Lewy body disease, you get a different pathology, which is the actual Lewy bodies. And if they're located in specifically in the substantia nigra, that's what you see in Parkinson's disease. But in Lewy body disease, it goes well beyond the substantia nigra into the neocortex, and that gives you all that cognitive presentation. So there's kind of this idea that there's a spectrum of cognition and a pathology between Parkinson's disease dementia and full-blown Lewy body disease, where it's much more widespread and much more of a cognitive, but as well motor presentation. And in frontotemporal dementia, you see a very different pathology with TDP43, and we spoke about the MAPT mutation families and so on. So the course and onset is different between these, and the histological presentation is different. And again, you can pull up that article if you want to look at the details. But I put in this slide because I really want to emphasize that mixed brain pathologies are the much more common cause of dementia. So it's rare to have an isolated pathology. And so we published many years ago now, already in 2007, that mixed brain pathologies account for most dementia cases in community dwelling elder persons. This is not necessarily what you see in the clinic. In the clinic, we see kind of the tip of the iceberg. But when you're thinking at the population level, how can we make an impact on dementia? You can't just treat Alzheimer's disease, because dementia is many things together happening in the brain. And so if all you just concentrate on Alzheimer's disease, you're really missing the boat, quite frankly. Okay, so let's think about cerebrovascular disease. So mixed brain pathologies account for most dementia cases. We already made that case. So in dementia, that's why you have this figure here with lots of hashes, because mixed pathology is far more common than Alzheimer's disease alone or brain infarctions alone. But even in people without dementia, you see a lot of mixed pathology, and you see a lot of pathology itself. So having multiple diagnoses at 3 time points, having multiple diagnoses increases your risk by 3-fold to have dementia. So this is really an important entity to recognize. And in a subsequent study published several years later, we showed that there's lots of multiple pathologies in somebody that we clinically call having Alzheimer's disease dementia. There's actually a lot of vascular pathology, which is the V, which is in like more than 2/3 of cases here in these blue panels. And there's other diagnoses and so on. But even in MCI, there's lots of multiple pathologies, as you see here in yellow and in blue over here. And even in normal cognitive this is no cognitive impairment in people with normal cognition. There's a lot of pathology, and including a lot of multiple pathologies as well. So dementia causes are most commonly mixed. And Alzheimer's disease, amongst single entities, Alzheimer's disease is the single most common cause if you're only looking at one pathology itself. So what I wanted to leave you with, though, is that there's not a perfect correlation between level of pathology and the clinical presentation. There are people who have resilience to pathology. So this is when you look at the postmortem brain that shows little or no pathology. And so we call them resilient to developing pathology. And so we really need to understand what protects people from developing pathology to begin with. And then there are people who have resistance to pathology, and this is that they have pathology in the brain, but despite having a certain level of, say, Alzheimer's plaques that you can see under the microscope, they really had little or no clinical expression of cognitive impairment or dementia. So these are people who have cognitive reserve. So they do have the pathology in the brain, but they don't express, during lifetime, there was no clinical expression of that pathology, and they have what we call cognitive reserve. And this is a really fascinating group of people to study, because that can allow us to understand how can we prevent somebody from developing a dementia, even if they have pathology in the brain. So there's a lot of research around this space, and I'll just give you one little tidbit of an area that is really exciting, is that we know that higher levels of education protect people from developing cognitive decline and dementia, even if they have a lot of amyloid in the brain. And so education is something that we're able to modify. And education has been really promoted across many different countries now worldwide. And education today in the century that we live in is higher than it's ever been in past centuries, right? Worldwide, there's really a push to educate children, to keep them in school for longer. And this has a protective effect on the brain. And that's something that at a population-based, public health initiative level, we could really promote. So the pathophysiology is complex. There's been lots of advances in recent decades, but there's a lot more to understand. But we know now more about risk factors and protective factors for dementia. There's non-modifiable risk factors. So we age, and as we age, we're much more likely to develop dementia. So when you look at people who are aged 85, about one in two people develop a dementia if they live that long. There are many more women with dementia. We need to understand why that is. It might be that they live longer, but there's research to suggest that even when you control for mortality of men who die at a younger age, typically there's something else happening. So is it the chromosomes? Is it the gonads? Is it the hormones themselves? What is playing a role in sex differences in dementia? We know that there's a role for family history of dementia, especially in young onset. We know that genetics plays a role, but really exciting is that we're understanding a lot more about modifiable risk factors for dementia. So these are things like vascular risk factors, diabetes, hypertension, obesity, body mass index, cardiovascular disease, stroke. These are things that we can modify. We know how to modify these risk factors. We know how to prevent. We know how to treat if somebody develops it. So how can we have an impact there? And we're learning a lot more across a variety of different lifestyle, environmental factors, whether it be cognitive function, physical function that protects the brain, social activities, healthy diets, whether it be Mediterranean or the MIND diet that was developed at Rush, healthy sleep behaviors, psychological stress. I mean, I don't need to be telling this group again of psychiatrists, but psychological stress that plays a role in dementia. Certain professions are not good for the brain, whether you're exposed to repeated traumas, for example, in sports, whether you work in the army and you have head trauma from being exposed in war situations, for example. There's toxins that affects the brains clearly. There's psychosocial environment factors like food deserts, built environment, air and noise pollution, and so many more things that we know a lot more about today that are potentially modifiable. And if you identify those risk factors and work at the individual level, but also at the population level for reducing, air pollution and so on, we can have an impact on dementia. So we certainly are in a new era now. There's a lot of exciting research and some novel therapies that are, after many years of only having symptomatic treatments that we can now offer our patients. So I wanted to start with this really landmark paper that was published 3.5 years ago by the Lancet Commission that identified 12 risk factors across the lifespan. So that's what's shown on the figure on the right, that across these 12 risk factors, if you modify them, you could potentially reduce dementia by 40%. I think that number is a little bit high, to tell you the truth. These are not, while they're modifiable, again, having an impact at the population-based level is very challenging and difficult. But in early life, we already spoke about education. Education is a risk factor. Flip side is higher education is a protective factor against dementia. So you might be able to modify a significant group of people having dementia by early life interventions. What about in the midlife? There are things like hearing loss, trauma, hypertension, alcohol, excessive alcohol use, obesity that have impacts on dementia. And then in late life, you have things like smoking, depression, social isolation, physical inactivity, air pollution, diabetes, and others. So adding up these 12 risk factors, you can potentially impact 40% of dementia. And a lot of these risk factors I put with the yellow, I added the yellow arrows to this beautiful figure, just to highlight some of the vascular risk factors that we ourselves are working on at Rush, where we think we can have a significant impact, whether it be hypertension, obesity, diabetes, different types of your, phases of your life that we're trying to really understand in detail. So here's an earlier study that we published 20 years ago now, on diabetes and how it doubles your risk of dementia. Here's the hazard ratio when you compare several hundred people with and without diabetes, that you have a twofold increased risk of of dementia, and also you have a faster rate of cognitive decline in this domain of perceptual speed. And what diabetes can do is that it causes not only frank infarcts in the brain, but very, very small infarcts. And the infarcts, even when you account for large infarcts and when you account for Alzheimer's disease pathology, those microinfarcts significantly increase your risk of dementia and are associated with a fast slope of cognitive decline above and beyond the other neuropathologies. And as I already pointed out, this exciting paper we published in Lancet Neurology a few years ago, 8 years ago, that cerebral vessels themselves, atherosclerosis and arteriolosclerosis, have additive effects to Alzheimer's disease in purple, to large infarcts and small infarcts. So atherosclerosis in red and arteriolosclerosis in blue have additive effects above and beyond, even when you control the other pathologies, to your probability of developing dementia and your risk of cognitive decline. And blood pressure itself, we know a lot about mean blood pressure, but what about changes in blood pressure and how that relates to postmortem pathology under the microscope? We know that it is associated with increased risk of cerebrovascular disease, and there was even some indication that blood pressure can be associated with additional Alzheimer's disease pathology in a paper we published in Neurology a few years ago in almost 1,300 people. So lots of areas where we have the opportunity to intervene. What about Alzheimer's disease itself? Well, there's been certainly, this amyloid cascade hypothesis that's about a good 20 years old now, that generated a whole slew of research, which kind of led the path towards treatments for amyloid itself, which I'm going to talk with you about in just a second here. But we know that Alzheimer's disease is much more beyond amyloid, and it really is a multifactorial complex disease with lots of gene-environment interactions. So we think now that if all you do is target amyloid, that you're still missing the boat. It's much more complicated than that. So while this is absolutely a start, that there's a lot more we need to do. And we're in the era now of thinking of a multi-pronged approach. Can we develop drugs that have not only effects on amyloid, but what about tau? What about synapses? What about the neurodegeneration and the atrophy? So we're thinking well beyond amyloid. But let's talk a little bit about what we know about amyloid. And the interesting thing with the amyloid plaques is that research has now shown that while you develop the symptoms, say in your 70s and 80s, people develop cognitive impairment and can have a full-blown dementia, we know that the amyloid plaques really start a good 10 years, and some studies suggest even 15 or 20 years before the first clinical symptoms. So the pathology of Alzheimer's disease starts in the brain many years, 10, 15, 20 years before you actually develop the clinical symptoms. And there's, different trajectories for different people, given their socioeconomic status, their education, which we spoke about, their vascular risk factors, and a whole slew of other things. But the point is that the amyloid plaques do start many years before, and it gives us this window of opportunity to intervene. a much more kind of complicated figure, which was started by Cliff Jack at the Mayo Clinic actually many years before this. And there's been many dozen now kind of revisions and updates to this figure. But it's the notion that the clinical expression of dementia, which is in brown here, starts later in life. But we know that, for example, subtle neurocognitive impairment starts even earlier, and you can detect that on detailed neuropsychological testing in the deep purple. And then in the blue line, that we can identify structural brain MRI changes even before the neuropsychological changes. For example, here, the mesiotemporal lobe atrophy and other changes that we can detect. And even before that, you get changes in tau that you can pick up on CSF testing by lumbar puncture. You get changes in synaptic function, which you might measure by FDG, PET, or functional MRI. And then even before that, you can get the accumulation of amyloid beta, which is even in the preclinical stages before you even have some subtle cognitive changes, frank MCI, and then or frank dementia. So there's different biomarkers can be identified at different stages, clinical stages of disease, and there's even more that don't appear in this chart because this figure is already quite old. And so we're understanding a lot more about the different biomarkers and what we can test for and what we recognize. And it gives us the opportunities to have interventions not only in MCI dementia stages, which we are intervening at now, but in the preclinical stages, which is really exciting because ultimately we want to prevent somebody from even developing cognitive decline to begin with. So I wanted to leave you with a few slides on when to refer to the specialist. Well, if you're thinking of a monoclonal antibody for amyloid, this is something that typically is done in a subspecialty clinic at this point. These are very complicated drugs. We have to have lots of discussions with the patients and families about their interest, about their expectations, because I have seen quite a few instances where there's a mismatch between, this is going to be a cure for me, and we really have to kind of temper the expectations of patients and families. We have to discuss the pros and cons. We want to talk about the process. It's very involved. Getting a drug like the monoclonal antibody, you have to come in every 2 weeks for an infusion, which is not easy. We need to monitor you by MRI. We need to discuss side effects and monitor for those, look for complications. Some patients, most patients, I have to say, after we have these conversations, do not want to proceed. But if you are thinking about referring a patient, you might want to do some basic workup in your clinic because you might want to see whether they even qualify. Are they at the right stage of disease? These drugs are really only indicated in MCI due to Alzheimer's disease or mild dementia due to Alzheimer's disease. So you want to do a workup. You want to confirm that they do indeed have amyloid positivity. So you might want to, if you're comfortable, you might want to order some of the testing to identify that there's amyloid. We don't want to be giving a monoclonal antibody against amyloid in somebody who does not have amyloid in the brain. So we need to do a workup. And you might want to evaluate them for some basic exclusionary criteria. If they have more than 4 microhemorrhages on their MRI or a lot of cerebrovascular disease on the MRI, they really don't qualify for these antibodies. If they're on anticoagulants, they don't qualify for these antibodies. You might want to order ApoE genetic testing because this is really informative in our discussion with the family members and the patients about their risk stratification. So we really need to know, do they have 1 or 2 copies of ApoE4 and what that means for the risk. And so then you can refer to their local prescribing provider, somebody who prescribed these antibodies who's familiar and comfortable prescribing if they qualify. So what do these drugs do? So what we know about these drugs, and there was a recent publication that you can pull up if you want to know, but really most people now who prescribe these drugs are focusing on lecanemab, or Leqembi is the trade name. We by and large do not use any more aducanumab. In fact, it's not being manufactured anymore. And there's a whole slew of controversy around that drug that came out first, but we're not using it anymore. And then recent studies show that these 2 drugs in phase 3 studies did not reach the primary endpoints of clinical efficacy, so these are not being used. Or not available, I should say, they're not FDA approved. There's discussion, there's a lot of, FDA is evaluating data for donanemab and called a panel to review the data. So this is under review now at the FDA. But certainly this was the first drug, aducanumab, to be approved, no longer used, as I said. Lecanemab was the second drug to be approved, first on accelerated approval and now has full approval and is being used in a small number of patients who qualify and who want to proceed with the treatment. So what was that based on? It was based on this New England Journal of Medicine paper for lecanemab that showed efficacy on the CDR sum of boxes, the Clinical Dementia Rating Scale sum of boxes, that showed a significant difference at 18 months in lecanemab patients versus placebo. Yes, it was a small effect, but it was statistically significant on a clinical scale. But it also, certainly the big excitement was that it removed amyloid significantly from the brain. So people who had amyloid at baseline at certain level, there was no difference here, but lecanemab, it removed a lot of the lecanemab from the brain on their score that they provided here. So you can again pull the full article if you want to see all the details, but essentially it showed efficacy on all endpoints, primary and secondary endpoints, clinical and biomarker endpoints. And so based on that, it was FDA approved. Now, really quickly, because we're at the end of the hour, is safety issues are a huge concern with lecanemab. So we do not start these drugs lightly. We have very detailed conversations with patients. There is a difference between lecanemab and placebo on adverse events. And for example, 22% versus 44%, so doubling of adverse events, and serious adverse events are also higher, so 11% in placebo versus 14% in the treatment group. There wasn't a significant difference in death, which is obviously a very important outcome to look at, but there were few numbers of deaths in the study. But the difference with the adverse events that occurred in more than 5% of participants in the treatment group are up here, including infusion-related reactions, which is much higher than in placebo, ARIA, which we'll come to in a second in the next slide, which is higher than doubling than in placebo, and headaches. Those are the main ones to look at. So what are ARIA? ARIAs are amyloid-related imaging abnormalities, and they could be ARIA-E, as shown here, edema, or ARIA-H, hemorrhage. And so this is what it looks like for the edema and for the hemorrhages that you can detect on the GRE, or even better yet is the SWI sequence of the imaging. And so we look at imaging before we start lecanemab treatment, and we follow during the course of treatment. We repeat the MRIs at specific time points, or even more frequently if they're symptomatic. We do want to get imaging to see whether there's an edema or hemorrhage. And of course, this is a concerning complication. In most people, it's asymptomatic, although in a minority of people, it is symptomatic. And worst case scenario, significantly symptomatic. And of course, the worry is that they have ongoing symptoms or death. So this is not something to be lightly considered. And whether you have an ApoE genotype, that really confers much significantly increased risk. And so we really discuss this very carefully with our patients. Now, shifting to, and I'm coming to my last slide here, when else to refer to clinic is if you have a patient with atypical features, if they're young, if their onset of their dementia is young, if they have a rapidly progressive course, if they have other neurological features or systemic features. And so this gives you some examples, again, from that JAMA article of when to refer to a specialty clinic. And I'm going to kind of go quickly to say that our clinic is providing consultation for patients with complicated cases, if they're young, if you're not sure of the etiology, if you're not sure about the management, if you want to refer to for lecanemab. So this is our phone number and this is our website. We also are very happy if you want to refer patients simply for research. We can bypass the clinic. They don't have to wait to have a clinical appointment, and we can get them into research studies and get them, potentially into therapies that they wouldn't otherwise have access to, and that's our phone number. And so we really can't advance the science without having people participate in our studies and contribute to the science. And here are some resources, again, from that same article that I spoke about before. So you can pull the article, and there's some useful resources to offer these patients as they, as they're facing just so many barriers to care and help that they need. So I'm going to stop at that. Here's my email if you have any questions. And